Hello, I'm Dr. Laukinen, and I'm going to be discussing radiation treatment for lymph nodes in relation to breast cancer. And you may be looking at this because you have an appointment with me in the near term, and we're going to discuss this. And so I look forward to meeting you. So, first of all, why do we look at radiation treatment for lymph nodes? And the dominant reason is that the goal is to have the very lowest possible chance that the cancer will grow back in the treated area, and we'll have a look at exactly what that area is. But the idea is that breast cancer cells can sneak out to the lymph nodes and the soft tissues around the lymph nodes. Then a second reason is that some studies show that uh, by doing such treatment, that there's a lower likelihood of the cancer coming back. The so-called disease-free survival is potentially improved. So where are the lymph nodes? Well, in several locations. And the first is in the breast itself, and then tracking up to the area under the arm where the arm attaches to the body, and then following upwards with blood vessels supplying the arm, going all the way up to the uh, inner aspect of the collarbone area. And just to emphasize that they're not randomly distributed, but rather they follow a general highway that's laid out with the blood vessels. And the highest level is, in fact, just above the inner part of the collarbone, the so-called supraclavicular lymph node. But there are some less obvious lymph node locations, and they're the so-called internal mammary lymph nodes. And if we think about the breastbone, on either side of the breastbone, at its underside, there are little tracks for lymph nodes, and they're a potential hiding place for breast cancer cells. And those lymph nodes don't just stand by themselves, but rather they're connected by a delicate, big meshwork of tissue fluid channels. And of course, cancer cells can travel along those channels. So whenever we think about lymph nodes for treatment, we think about what side of the body. So area that's treated is the lymph node group that's on the same side as the cancer. And here's a picture of what uh, a radiation beam that's part of a lymph node treatment strategy would look like. It's ultimately customized to the extent of the node involvement and the nature of the surgery that's been done. And this shows some radiation planning in progress where high energy radiation beams are designed to cover that area that we've been talking about. And those central lymph nodes by the breastbone, they're handled usually together with the breast or the chest wall that's being treated at the same time. And the little yellow arrow shows how these lymph nodes are, in fact, not on the outside, but on the inside, just at the inner edge of the chest wall. This shows again the little red circles that are beside the breastbone in the middle, where the arrows are pointing. Those are the lymph node areas. You can imagine, so following those purple lines, if you have a radiation beam that is skimming across that area, it can deliver energy to those lymph nodes. And putting it all together, this is a radiation design model. This is a person that has the breast being treated and the lymph nodes. And if we look at the top, the area rises up into just the area above the collarbone. You'll notice there's a portion of coverage at the back, and that, of course, is because the radiation beams travel back to front to cover that. So there's some radiation delivered, in fact, to the upper back on that side. You'll notice that the area that's orange comes across the middle, and that's where the radiation beam is being adjusted so that it covers those lymph nodes deep to the breastbone. And these treatments usually are delivered on a schedule that takes 16 sessions, so a little bit more than 3 weeks. And it takes around a half hour or potentially a bit more in the treatment room to have this treatment delivered. So now we'll talk about side effects. They typically don't arise in the first week or two, but by the third week they can be evident and they can linger for a few weeks. That's the so-called acute or visible early side effects. And as you can see when you look at these pictures, there's skin in the target area, and skin reacts to radiation treatment by absorbing the energy. The skin layers are put out of their ordinary routine, and it's common to develop an effect that's not unlike a sunburn, and it's an irritating place to have a sunburn type effect. And in fact, if a person has fairly deep skin folds in the area, and they notice that more, they can get, chafing and irritation, and there's a care plan for that. And happily, that typically settles down about 3 weeks or so after the treatment has been finished. Another skin area is on the chest wall itself, and where we've circled, that's the area beyond the midline. And the other area that's a bit unexpected is that uppermost area of the back on the treated side. And again, that skin effect running its course over 3 to 4 weeks. What about delayed effects? Things that might happen not during the treatment, not in the few weeks after, but potentially months and years later. Well, the one thing that we all think about is lymphedema, and that's a swelling of the arm or hand that can occur because small amounts of scar tissue are formed that obstruct those little micro lymph tissue fluid channels. And so if fluid has to work harder to drain back from the arm, it might pool there. And lymphedema tends to stay if it arises, but it can be managed. And if we imagine these channels, microchannels becoming partly blocked, that can happen with surgery because the surgery causes some disruptive scarring. And over the years, the risk of lymphedema with surgery was about 4 or 5%. But as your surgeon probably explained, the risk of that occurring with surgery has become much less when surgery has become much more limited. So if a person has very limited surgery, the risk is small, and then the added risk of radiation is smaller as well. So one might look at a combined risk of about 8% of mild to moderate, but when there's lesser surgery and where a person doesn't have a lot of scarring or fibrous tissue to start with, the risk would be lower than 4 or 5%. And most lymphedema is happily fairly readily manageable. What about fibrous tissue which can form after radiation, causing stiffness around the shoulder joint? That can happen 2 or 3% of cases. And as we saw from those planning pictures, a tiny cap of lung tissue is taken into the treated area because it's deep to where all of these treated structures are. And a little bit of scar tissue can form in that place as well. But if a person has anything close to normal lung function, it's such a tiny proportion of the total that they would not be aware of it. So just to summarize, regional node radiation is done to lower the chance that the cancer will come back in the area, and it may improve long-term outcomes. Its role has been proven if a person has a fair amount of cancer either in the breast or in the lymph nodes to start with, or even with a lesser amount of cancer but definite proven involved lymph nodes. And it also has a place where chemotherapy has been given before surgery, and yet there's a meaningful amount of cancer is still found after the chemotherapy, either in the breast or the nodes. And one gray area where policy has been slowly changing is that if the chemotherapy has completely cleared the cancer, it may be feasible to leave out the nodal radiation. And each case is looked at on its own merits. And those potential benefits are weighed against the bother of those early skin effects, which everybody has some of, and the possibility of later fibrous tissue changes that can affect the lymph channels and that small cap of lung tissue at the top of the lung. Happily, some other theoretical cancer risks haven't been borne out. We saw how the radiation beams come up to just above the collarbone, and of course the thyroid is sitting next to that, but fairly careful studies haven't shown radiation-induced second cancers of the thyroid that are statistically detectable. And the other bone and soft tissue structures and the nerve structures in that area, we could say hold up well to this treatment. So thanks very much for following along with this.